Welcome. This is Ann Huml from the Division of Nephrology and the Center for Reducing Health Disparities at Case Western Reserve University in Cleveland, Ohio. On behalf of my co-authors, I am delighted to take part in this podcast about our article entitled Outcomes of Deceased Donor Kidney Offers to Patients at the Top of the Waiting List, published in CJASN this month. Overall, about 600,000 Americans have end-stage renal disease and require chronic dialysis treatment or a kidney transplant to survive. Compared to chronic dialysis, kidney transplantation results in better survival and quality of life and lower healthcare costs. Approximately 100,000 patients are listed for a kidney transplant. However, only 17,000 transplants occur per year, with two-thirds of these coming from deceased donor organs. Annually, over 8,000 patients either die waiting for a kidney transplant or are removed from the waiting list for being too ill. Waiting times vary based on geography, but it is not unusual for patients to wait upwards of 5 years for a kidney transplant. There are sizable race, gender, and socioeconomic disparities in access to kidney transplantation. In this study, we evaluated the outcomes of deceased donor kidney offers and their association with donor and wait-listed patient characteristics. Differences in kidney offer outcomes to patients at the top of the waiting list may contribute to disparities in transplantation. When a deceased donor organ becomes available, a match run list is created that ranks potential recipients in priority order based upon several characteristics, including waiting time and immunologic criteria. At the discretion of the transplant center, organ offers to patients on their waiting list can be accepted for transplant or refused for a particular patient. The offers continue down the match run list in sequential order. For each potential recipient in whom the organ is not transplanted, a refusal code is generated and cataloged within the United Network of Organ Sharing, or UNOS. UNOS identifies 37 unique refusal codes. We categorize them into donor-related, transplant center bypassed for pre-specified criteria, recipient-related, histocompatibility-related, program-related, or other reasons for refusal. We obtained data for deceased donor kidney offers of organs that were eventually transplanted between May 2007 and July 2012. From these data, we extracted transplant events and refusal codes, as well as donor and waitlisted patient characteristics. Over 7 million organ offers involving more than 30,000 donors and 175,000 waitlisted patients were evaluated. 0.7% of the offers resulted in transplant. Most commonly, donor-related factors and transplant center bypass were the reasons for refusal, each occurring 45% of the time. Less common reasons for refusal were recipient, program, or histocompatibility reasons. In a multivariate analysis, we developed separate logistic regression models to analyze the relationship between donor and waitlisted patient characteristics and the outcomes of the offers. Controlling for all other characteristics, offers were less likely to be accepted if a waitlisted patient was Hispanic, male, had hypertension as a cause of kidney failure, or had a higher body mass index. On the other hand, offers were more likely to be accepted for patients with high panel of reactive antibodies. Considering donor characteristics, organs were less likely to be accepted from donors with a history of hypertension, diabetes, high terminal creatinine, or cardiac death. The lower the offer number, the more likely the organ was accepted for a transplant. As a corollary, organs with fewer offers were more likely to be refused due to recipient and histocompatibility factors. Finally, transplant centers with more minority waitlisted patients were less likely to accept offers, while high-volume centers were more likely to accept offers. The distribution of refusal codes varied across transplant centers. Our results have implications for patients, transplant providers, and policymakers. Patients should be aware of how the organ offer process works. Transplant providers can compare their practices to national trends and strategize how to change their center's practices to optimize acceptances by monitoring refusals of offers, both among all waitlisted patients and among specific subgroups. Policymakers may be able to develop performance metrics to assess the offer process and disseminate best practices to providers at centers with lower acceptance rates. Further work is needed to better understand and improve the offer process to maximize the efficiency and equity of organ allocation.
This podcast is copyrighted by the American Society of Nephrology, all rights reserved. All content in this podcast is for informational purposes only and is not intended to be medical advice. This podcast should not be used in a medical emergency or for the diagnosis or treatment of any medical condition. Please consult your doctor or other qualified healthcare provider if you have any questions about any medical condition or before taking any drug, changing your diet, or commencing or discontinuing any course of treatment. Thank you for listening to this podcast of the American Society of Nephrology.